All right, welcome back to The Explainer, everyone. Specifically, to all you future physicians and medical students tuning in. Today, we're tackling a deeply concerning, rapidly evolving issue that is absolutely going to impact your future clinical practice. We are looking at the frankly alarming epidemiological shift of early onset cancers. You know, for decades, oncological screening and diagnostic suspicion have been heavily weighted toward older demographics. But the data is shifting right under our feet, and as it shifts, it's exposing a really critical vulnerability in our healthcare systems: age bias. So in this explainer, we're going to unpack the hard data behind this rising trend, examine the leading risk factors, and discuss exactly why a patient's age can literally no longer be used to dismiss classic pathological red flags.
Now, to really grasp the clinical weight of all of this data, we have to start with the human cost. Take a look at this quote. It's from Carolyn Moosdale, the mother of 23-year-old Bradley Coombs. Bradley was a remarkably fit, super healthy young guy from Portsmouth, literally on the verge of signing a semi-professional football contract. But he tragically passed away from bowel cancer. And what's just absolutely devastating about Bradley's case is that he was repeatedly dismissed by medical professionals simply because he was perceived as being too young to have the disease.
So the crucial point is that Bradley was not some asymptomatic patient with a really subtle presentation. No, he was presenting with glaring, textbook clinical red flags. We're talking severe weight loss, persistent abdominal pain, chronic diarrhea, and blood in his stools. Yet, because of his age, these symptoms were not aggressively investigated for 18 long months. By the time he finally got a diagnostic colonoscopy, the tumor had grown so large that it physically blocked the camera from entering. The subsequent surgery and chemotherapy were simply not enough, and he died. This right here is the ultimate tragic consequence of age bias in diagnostics.
Okay, let's dive right into this. We're going to break this down into 4 parts. Number 1, the epidemiological shift. Number 2, auditing the risk factors. Number 3, the unexplained cases. And 4, our clinical takeaways. Starting with Section 1, the epidemiological shift, zooming out to the macro data. Let's step back from Bradley's individual case for a second and look at the broader reality across the whole population. A major analysis by scientists at the Institute of Cancer Research and Imperial College London has given us a really clear look at exactly what's going on out there.
The data shows that 11 specific cancers are becoming increasingly common in people in their late teens, 20s, 30s, and 40s. Check out this list. We're seeing rising rates of thyroid, multiple myeloma, liver, kidney, endometrial, mouth, and ovarian cancers. We're even seeing an uptick in cancers that are traditionally quite rare, like gallbladder and pancreatic cancers. But I want to draw your attention specifically to bowel and breast cancers. These are the most common ones hitting younger adults, combining for a staggering 11,500 cases a year. That's a huge number for this demographic.
And this brilliantly illustrates a really vital nuance in the epidemiology. Not all of these increases are happening in a vacuum. Of the 11 cancers we just looked at, 9 of them, including breast, thyroid, and liver cancer, are increasing across all age groups, not just the young. But notice the true anomaly highlighted here. Bowel and ovarian cancers are increasing exclusively in the young demographic. This points to a highly specific generational shift occurring that we absolutely need to investigate.
Which brings us to Section 2, auditing the risk factors, ruling out and ruling in. Now, as future clinicians, your very first instinct here should be to audit the known etiological risk factors to figure out what's driving this shift. We have to rule out the usual suspects before we can rule anything in.
Well, the researchers did exactly that. In Step 1, they audited the established lifestyle behaviors we know increase cancer risk, right? Things like smoking levels, alcohol consumption, a lack of physical exercise, high intake of red and processed meat, diets low in fiber. But look at Step 2. When they observed the actual population trends for these specific behaviors, they found that they are all either getting better or just staying the same across the younger demographic. Therefore, in Step 3, we have to conclude that these historical lifestyle culprits actually cannot explain why cancer has increased in this specific age group.
So what does correlate? According to the report, the only data point that aligns with this increase in early onset cancer is the parallel rise in rates of overweight and obesity. This is a trend that's been climbing steadily since the 1990s, and it perfectly mirrors the trajectory of these cancer diagnoses in younger populations.
Let's look at how this builds the pathological picture, because you all need the why behind the epidemiology, right? Why does obesity drive cancer risk? Well, extra fat tissue isn't just inert storage like we used to think. It's increasingly understood to act as a highly active endocrine organ. It alters hormone levels in the body, particularly insulin.
And these hormonal fluctuations create an environment that can significantly amp up the risk of cellular mutation and subsequent cancer development. This is that physiological bridge connecting the lifestyle trend directly to the oncological reality.
Moving into Section 3, the unexplained cases, the diagnostic gap. Because while the obesity hypothesis gives us a solid foundation, there's a massive gap here that really should ignite your scientific curiosity.
Now, what's really interesting about this slide is how starkly we can visualize what we don't know. Researchers estimate that out of 100 extra cases of early-onset bowel cancer, only about 20 can actually be attributed to excess weight. That leaves 80 out of 100 cases completely unexplained. Think about that. Obesity is a factor, sure, but it is far from the whole story.
So what on earth is filling that 80% gap? Well, Professor Mark Gunter and his team at Imperial College London note that there's still a ton we just don't know, but the search for novel risk factors is aggressively underway. Here are the emerging hypotheses they're currently investigating. We're looking at the ubiquitous presence of ultra-processed foods in modern diets, exposure to PFAS or forever chemicals, widespread antibiotic use altering human biology, sweetened drinks, systemic inflammation, air pollution, disruptions to our gut bacteria, the agricultural use of weed killers, and finally the possibility that we're simply just getting better at detecting these cancers at a younger age. These are the frontiers of oncological research you're going to be stepping right into.
All right, Section 4, clinical takeaways, grounding the data for future practice. Let's translate this epidemiological data into actionable insights for your future medical practice. How should all of this actually change the way you interact with your patients?
First things first, we absolutely have to maintain clinical perspective. While the percentage increases in early-onset cancer are deeply concerning, the absolute risk remains relatively low. Roughly 1 in 1,000 young people, so those in their 20s, 30s, and 40s, will get a cancer diagnosis each year. Now, this is still heavily dwarfed by older age groups, where the rate is around 1 in 100. So the takeaway here is not to incite panic, but rather to foster a heightened, rational vigilance in your practice.
Second, we can't lose sight of the basics, prevention. Professor Montserrat Garcia-Closas from the Institute of Cancer Research emphasizes that while this news is worrisome, we still have incredibly powerful tools at our disposal. It's estimated that nearly 40% of all cancers worldwide can be prevented entirely with basic lifestyle choices, things like maintaining a healthy weight, staying physically active, and not smoking. Your role as a physician isn't just to diagnose the extra early-onset cancers, it's to actively advocate for holistic health to prevent all cancers right out of the gate.
Which brings us to a final thought. The real tragedy of Bradley Coombs wasn't just that he got sick, it's that the system failed to see his sickness because of a preconceived notion about his age. The data clearly shows the landscape of cancer is shifting younger. So as future clinicians, I leave you with this. How will you ensure that a patient's age never blinds you to the red flags of their pathology? It's a question that could very well save your future patients' lives. Thank you so much for joining me for this explainer. Stay curious, and I'll see you next time.